Good evening. Welcome to our webinar. My name is Dr. Tariq Abdellatif Ibrahim. I am the Acting Director of Quality Administration in Qasim Health Cluster. You will be hearing a presentation from Dr. Aid Al-Rashidi, who will be speaking to us on good governance in the promotion of patient safety in healthcare organization. Dr. Aid Al-Rashidi is a healthcare quality professional and currently assigned as a Vice President for Quality and Clinical Excellence in Qasim Health Cluster in Kingdom of Saudi Arabia. He has many professional certificates in health administration and quality management and patient safety too, like Master in Health Administration and CBHQ certification and Master Black Belt. Mr. Rashidi specializes in applying his expertise and the quality management knowledge, healthcare quality, patient safety, and process improvement that constantly exceeds the improvement goal of his client inside and outside the Qasim region. Dear participant, please note that during our presentation, the question will be at the end of the session and post in the QA icon. So our speaker will answer them gladly. Now, moving along to our session, please welcome Dr. Aid to deliver the presentation on this very timely subject. Mr. Aid.
Thank you, Dr. Tariq. Assalamu alaikum wa rahmatullahi wa barakatuh. First of all, I wanted to say thank you to the Saudi Patient Safety Center. I'm honored and thanking them to give me opportunities to be with you today. I hope my presentation today will meet your expectation. I will talk about good governance in the promoting of patient safety in healthcare system organization. And during our presentation will be divided in the 4 sessions. First session, we're talking about definition, introduction, definition, and concept. And second session, we will talk about patient safety strategies. And third section, we'll talk about essential patient safety tools. And the fourth session, we will talk about role of governance and role of the employee who working in organization for implementation of patient safety. I hope, inshallah, during our presentation, we will covering all the role of the governance in the promoting of patient safety. Also, we have 3 poll questions, and inshallah, during the presentation, you will find this poll question. I hope to all of you participate in this poll questions. Our objective, we will talk about, inshallah, we will cover explain organization journey and journey to the delivery of safe and reliable care every time for every patient, illustrate organizational role in sustaining a culture of the safeties through governance support, and describing safety governance and approaching taken to minimize the risk of patient harm across entity or systems, and promoting the steering and role-making functions such as policies, regulation, and standards. Our first poll question: do you have an experience in implementation of patient safety concepts in your practice or your organizations?
Dear participant, please select one from the pool. Yes. Good. The results indicate that 82% of our attendees have an experience in patient safety. And this is a very interesting result for this session today.
Okay, good results. We will go through the first section. Our first section talking about patient safety introductions. We will covering the definition and patient safety dimension and patient safety concept. The introductions, as you know, the concept of safety culture is started in area outside the healthcare, such as airline industry and other organizations that were complex and hazardous, yet they were able to minimize the adverse effect through maintaining commitment to safety at every level. The challenging of making our healthcare system safer has been our priorities. And every one of us, it's our priority to be implementing a safety in our organization. Despite sensor and far-reaching efforts, however, the health industry still has far to go in making health care as safe as it needs to be. Creating a culture of patient safety is a major undertaking, and developing a strategic and infrastructure necessary affecting real and lasting change in system process and human behavior take hard work and perseverance. Okay, the first definition here, we talk about patient safety. I know you read many references and literatures talking about how they are defining the patient safety. We take two definitions here from AHRQ and also from NQF. First definition is talking about avoidance and prevention of patient injuries or adverse events resulting from the process of healthcare deliveries. We are trying to preventing our patients to have injury or any adverse event from our system. How we can do it? Yes, when we are do it, we can define it as patient safety. Second definitions, we're trying to do an action undertaken by individual and organization to protect healthcare recipients from being harmed by the effects of healthcare services. Here we are trying to put a rule and regulation to do anything help us to preventing the patient or any healthcare recipients in our organization to be harmed. This is the two definition. Also, we have a definition for patient safety cultures. The first definition from IHI, a culture of safeties and atmospheres, an atmosphere of mutual trust in which all staff members can talk freely about safety problems and how to solve them without fear of blame or punishment. When we find the staff, they are talking about any incidents or any safety issues freely, and they are not afraid from any blame or punishment. That means we will find there is a patient or there is a safety culture inside this organization. Second definition from AHRQ, the safety culture of an organization is the product of individual and group value, attitude, perception, competences, and patterns of behavior that determine the commitment to and the style and proficiencies of organization health and safety management. Well, also, this is product of individual, like for example, value, attitude, perception, competences to be built there to be build a safety culture inside the organizations. Okay, could you please share through chat about this pictures? If you look for this picture, the guys who are working with high-risk areas, he said, I don't have time to read all these safety rules. Could you please participate in chat and tell me what seemed to be the reason behind the staff behaviors? Okay. I'm sure the staff behavior, one of the challenging and others sometimes ignoring, and this is we will face it as a leader and governance, and even the chief of department inside the organization, we will find like the staff may working in high risk areas, but they don't have able to read the protocol or to accessing the policies and procedure inside the organization to looking for any safeties measurement inside his department or unit. This guy is working in high risk and he's dealing with high risk machines, and still he said, I don't have time to read all these safety rules. This is one of the challenging we will face it as a leaders inside the organization, but we need to work together with them, trying to make more awareness and we're trying to depend on system, not depend on individual, to let the system guide him to follow the rules of the safety inside his department or units. Okay, when we are talking about safety and when we're talking about, we need to look when we are trying to implement also safety programs inside our organization or institutions, we need to looking for the dimension of the safety. We have here 10 dimensions of safety. The first dimension, when our supervisor and manager expectation and action in promoting the patient safety. This is one of the important dimensions. We are all looking for the patient safety. Our decision, our expectation, anything related to our order or instructions, we should looking for the patient safety. Organizational learning, continuous improvement. We have a good organizational learning place, and we have areas to identify the weak areas and how to be improve this weak area. Teamwork within units. Very important to the teamwork spirit to be available within units and within organizations. Communication openness. This is one important thing. When the staff have freely to talk and they have know the rules of the communication, horizontal, vertical, top to down, down to top, and how they will follow and how to disseminate, like for example, meeting minutes or some KPIs or some policy procedure or some instruction came from based on the organization, approved organization. Feedback and communication about this is one of the important dimensions should be available in every organization. For example, in case of the staff initiate an incident report to the concerned department, and the report will take the cycles, we should in closing the loop, because here they will receive feedback about what's happened and what action taken to be not happen this incident in futures. Number 6, non-binative response to error. This is one of the important things. We have no blame cultures, and this is good to be let the staff reporting, even he able to be report himself in case of any incident happened because of his action taken. Adequate staffing. This is in case if you have shortage in staff and you have some staff, inadequate staff in your organization, maybe this is leading to any patient issues and maybe will be affecting harm to the patients. Hospital management support for patient safety. This is one of the important dimensions. Should be all our support and commitment from hospital leader and management to the patient safety. Teamwork across a hospital unit. And number 3, we talk about units, and here we're talking about hospital. That means should all staff who work in the hospital work and they are working as a team. Hospital hands-off and transition, effective communication should be so clear about the communication, and also communication between staff to be, with each other's department to department, based on the organization chart or based on the horizontal approved guideline for the communications. Okay, could you please look for these pictures and tell me your opinion also? Can you interpret this picture in terms of safety? Please, you can share through the chat, please. Can you interpret the picture in terms of safety? Okay, thank you for the response for these questions. When you're looking for these pictures, you find this guy is trying to fix the board in the wall, and this is workplace safety standards written there. But he's using some chair, table, cabinet to fix this safety standard. Yes, this is the problem of our some staff, or maybe he's taking a shortcut in one of the leading causes for workplace injuries. Be sure the use of correct tool for intended purpose. Is this tools is the correct tool for this purpose? No, but because of the shortcut, he wanted to fix it as, and this is the problem. And you know, when we are working quality or working as a patient safety officer or working as a leader, we should role model for others. We should follow the instruction. We fix it now, the safety standard, but we are not following the standard. I think important for us, never take the shortcuts to do something. You should follow the instruction, and even taking time, no problem. We can bring the ladder from other department or other units to fix this one, not using this chair or table to fix this one, and maybe will be affecting you and you will have workplace injuries. Regarding to the multi-causal theory about Swiss cheese model, this diagram by James Reyes in 1991. As you know, this system, and I wanted to talk about it because is show us a cheese slices, and this cheese slices is an organization is represent the organization's barriers for each process. There is a barrier, and this is a barrier. One of the barriers will be preventing the error or harm not reaching to the patients. But if you're looking for the hole inside the cheese slices, you will find this hole is like weaknesses, or sometimes this weaknesses inside the barriers, which will consist, for example, some hole is big and some hole is small, and vary in size and positions. But the problem in case of all these holes, based on the size, it will be in line. This is will be let the hazard reaching the patients. There is many areas, for example, funding and resources. In case if we have problem with fund and resources, that means we have one big hole there, and we have another hole in organization like cultures, incomplete policies. There is a policies or unavailability of policies, or sometimes policies available, but it's not covering some procedures need to be covered inside the policies, lack of some procedures, and also related to technical board designing or problem of maintenance about technical team. Also, there is a problem in responsibilities, no good awareness for the team. There is no job description for the teams, and this is also one of the others barriers. And the provider, and its lack of training, and there is a fatigue. They are working more than this is over load of work because of shortage of staff, and because of all this hole and weaknesses, the harm will be reached to the patients. Okay, we have in sweet cheese models, we have an active failure and latent failures. It's very important to understanding what the difference between active failure and latent failure. Active failure is usually associating with the human factors, what already from unsafe act by person in direct contact with the patient or systems. Is sometimes it's happening because of equipment, failure of equipment, but it's rare. And then active failure is contributed to the most of threats to the patients. And also we can say sharp end because it's happening from the health care professionals who are dealing and contacting with the patients. And this is incidents or mistake maybe will be affecting the safeties of or will be harm to the patients. The latent failures, something not happen yet, but may will happen, and because of administrative decision, and sometimes it's associated with healthcare system because related to policy procedures, unavailability of some resources and equipment, and these things may will lead to the errors. This is one of the important things to looking for, like blunt end. Yes, not yet happened, but may it happen. For example, one of the areas is unavailability of exit door, for example, unavailability of fire alarm detections, or they didn't have some equipment, PPE equipment, many things. It's unavailable sometimes, but in future, there is an incident will be happen and will be affecting the patients. And also latent failure many times is the most root cause analysis for active failure. And some active failures is the root cause of the active failure. If you're looking for the system here, you will find it from the latent failures. Here there is an example, slips and lapses. For example, unintentional good plan execute badly due to skill technical problem, mistake, unintentionally bad plan executed well, knowledge and problem, violation intentionally, deliberate deviation, attitude or behavior problems. This is another model talking about sharp end and blunt end. This is when you are do investigations for the sharp end, we will find there is it will focusing on the actions of clinicians, as I talk in the active failures, with already direct contact with the patient. But about blunt end is always focusing in the policies, procedures, system, resources, and constraint. But when you have a problem with this all systems, may will lead to the sharp end and will be affecting the staff when they are dealing with the patient directly. Dr. Lucien Lib, Harvard School of Public Health, he said, incompetent people are at most 1% of problem. The other 99 are good people trying to do a good job who make very simple mistake, and it's a process that sets them up to make this mistake. We wanted to think about the system first, how we can fix our system before we're looking for the individual mistake. Okay, I have a question here. How do we protect patient from harm? Could you please share it through chat? Okay, correct. First, we will organize an effective system. We'll organize an effective system. If we have good system and effective system. Second thing is clearly developed and structured process, standardization our process. You have a good structure for your process. Refer it to policies, guidelines, protocols, compliance with the standard of practice, best practice. When you are doing benchmarkings with standard national or internationals, individual competencies and periodic review. You have a good system for doing competencies for the individual who working and dealing directly with the patients. And this is review and periodic annually, biannually, quarterly. review for anything you sure to be look for their competencies. Okay, medical errors. When we're talking about medical error, we're talking about Institute of Medicine, IOM, define the medical error, the failures of a planned action to be completed as intended, or the use of a wrong plan to achieve an aim. Failure to execute a plan due to it's not completed, or sometimes we do shortcuts because we do a wrong plan to achieve our aims. Here about the first event and medical errors, and this we're talking about medical error, what already preventable failure in care process, near misses, close call, potential adverse event, and the adverse event, it's harm, injury caused by medical management, not by disease condition, non-preventable adverse event. When we give medication or we do intervention, sometimes adverse event will be happen, but not related to the disease itself, but sometimes because of our intervention, and sometimes we are not able to prevent it. But we have some overlap in between medical error and adverse event, preventable adverse event, what caused by error or system equipment failure, like for example, related to negligent adverse event or related to the attitude of the healthcare worker. Okay, we will go to the section 2. We'll talk about patient safety strategies. We will covering 3 strategies: mistake proofing, Bukayoka, and control and barrier and reduction of risk. The first one, strategic safety strategies. First one, mistake proofing, Bukayoka. This mistake proofing, Bukayoka, it has 6 principles of mistake proofing. 4 of them to prevent occurrence of human errors, and 2 to minimize the effect after occurrence of human errors. The first one is elimination, prevention, replacement, facilitations, and the 2 detection and mitigations. Eliminations, we are trying here to make product simplifications. Preventions, we're trying to make unique connector to avoid misconnected. This is an example. Replacement, for example, when we are replacing the manual system to the electronic system, automate the systems. Facilitation, we can do, for example, visual control, including color coding, for example. Detections, we have sensor in the production process, or we're trying to detect the error before it's happened. Like, for example, when you are doing an X-ray after the operation. And also we have mitigations, fuses to prevent overloading. And here also some example about outshot of heaters, circuit breakers, ready to administer medication, electronic health record, mandatory field. When you have in medical record, you should did some form or some space in form. You should mandatory before you go to the another page. Second, safety strategies, control and barriers. When we're talking about control and barriers, we have in each process, we have many areas we can say barrier or controls. This one is, for example, an X-ray confirmation of tube placement, verbal and telephone order repeat and read back, door alarms, surgical site confirmations, and time-out process. This is one of the examples. And I will give you here one story. It's happened when I was working in one hospital. There is a patient admitted to the ER and he has a fracture in his right knee. And all registration in the ER, it was left knee. And when shifted to the OR, shifted to the units, before shifted to the OR, all documentation, even the reservation order, sent it to the OR, it was left knee. But when reaching to the door of the OR, the surgical checklist done during the endorsement between the nursing who working in the units to the other nursing who work in the OR, they discovered the mistake or the incidents and they corrected. And we have another also areas for control in the timeout, because we'll do sign in and timeout, sign out. That means we put many barriers there, and we're trying to find a checkpoint, at least to try to minimize the incidents not reaching to patients, and we're trying our system to able to control and protect our patient from harm. The third strategy is here, reduction of risk management. As you know, risk management process to identify the risk, assessing the risk, and control the risk, and review the control. By example, identifying high-risk problem-prone, high-volume process, incident reporting through OVR, proactive and reactive investigation and monitoring. When we are talking about reactive and proactive risk reductions, reactive, that means after the incidents happen, investigating the significant event, example, sentinel events, we will do RCA. And RCA, I will cover it, inshallah, during when I talk about in section 3, when I'm talking about essential safety tools. Proactive, before treat detection, designing to redesigning high-risk process to preventing occurrence or reoccurrence of never event sentinel events. We will do here failure mode and effective analysis, FEMIA. We will try to find, we will try to do a plan for any risk or any wrong will happen in the future may lead into sentinel events. And also here we'll cover it, inshallah, during the section 3 about essential safety tools. Okay, our second pool question from the patient safety strategies that were mentioned. What are the commonly used strategies in your organizations? A, mistake proofing. B, control and barrier. C, risk reductions.
Okay, result. Well, according to the audience response, the most commonly used patient safety strategy is risk reduction. About 51% of our audience using this strategy in their work. The second one is controls and barrier, about 41% using this strategy. The least one is mistake proofing, which is 80%.
Okay, that means we think this is because risk reduction, failure mode, and effective analysis, and RCA is more commonly used in many organizations. And control and barrier, we have many areas for checkpoint and mistake proofing. Maybe this is a new for them, but we hope we cover it during our presentation. Okay, we will go.
Also, it is an excellent response, Dr. Aid, because this means we are working in a proactive manner. Usually, when we identify risks before, this is a good sign for our practice for patient safety. Not work after the incident occur, but in a proactive approach.
Okay. Correct. One of the important things to work proactive, not reactive. Section 3, patient safety essential tools. We will covering today. Ask me 3, speak up, 5Y, RCA, action hierarchy, failure mode and effective analysis, safety walk around, red rule, and safety adults. We'll go through this. Inshallah, we hope to be covered during our presentation. The first one we talk about patient safety essential tools. Ask me 3. One of the important tools to let a patient engaging in the healthcare system by let him to ask the question, what is my main problems, and what do I need to do, and why is it important for me to do this? As you know, as an educational programs that encouraging patients and family to ask 3 specific questions of their provider to better understanding their health condition and that they need to do to stay healthy. And also we should let our provider or our staff to plan themselves to discuss each question with the patient and their family during staying in a hospital. The patient, he has the right to asking, what is my main problem and what do I need to do and why is it important for me to do this? Designing by health literacy expert, Ask Me 3 is intended to help patients to become more active member of their healthcare team and to provide a critical platform to improve communication between patient families and healthcare professionals. Second, patient safety essential tools, Speak Up. This is also one of the important tools to be used to engaging the patient. Speak Up is the Joint Commission patient safety program launched in 2002. The goal of Speak Up is to help patients and their advocates become active in their care. The program had reached people in more than 70 countries and received numerous awards. It includes infographic education material, animated video, Speak Up materials, and message are affecting patient education tools, providing patients with information they need for safe care. The third patient safety essential tools, 5 whys. 5 whys to finding the root cause of problems. Ask why 5 times until root cause is reached, to asking why did this happen. And this technique is attributed to Tishi Ono, is a father of Toyota production system. And this is nowadays is talking about this method known as Lean. If you're looking for these examples by using 5 why, if you're looking for the picture number 1, this guy is asking, why has the machine stopped? And the answer was overload trip out. The second question, why? Why overload trip? Insufficient oil in shaft. Why insufficient oil pump inefficient? And number 4, why is pump not efficient? Pump drive shaft 1. Why is this shaft wall oil filter blocked with swarf? That means because of oil filter, this is main route for us when we are changing the filters, or we are doing maintenance or periodic maintenance to changing the filter from time to time. That means the machine, like a number 1, would not be stopped. We find the root cause because of using the tools of 5 whys. Okay. Number 4 of patient safety essential tools, cause and effective diagram. A cause and effective diagram is talking about to find, to help us to explore and display many causes to contribute to certain fact, effect, or outcome. Graphically display the relationship of the causes to the effect, and known by Ishikawa and Fishbone. I will go to the example directly. Look for the example here. Long test result time. This is, we have 5 category: environment, people's, equipment, method, material. There is also a problem related to clocks, inaccurate or don't agree, rounding, and we have about phone system to get to the equipment, and we have a lab not following FIFO, first in and first out, and material lab supplies. They have a problem with lab supply. I heard about people, secretary. And by this way, you are digging why and why by using Fishbone to find the main root cause analysis and contributory factor rated. Failure mode and effective analysis, a tool for conducting a systematic proactive analysis of process in which harm may occur. failure team represented all areas and expert in that their field, and asking to appropriate experts work together to asking the following are recorded: a step process, a failure, what could go wrong, and failure, what will be, would the failure happen, and what will be the consequence of each failure. I have here examples about a process. They have 8 questions. If you go through this 8 questions, what is the process, step, or future under investigation? Sponge counting in OR. Okay, in what ways could be step or future go wrong? Sponge count discrepancies. Yani there is a problem in the count of sponge. Okay, what is the impact of customer if this failure is not prevented or corrected? Retain sponge about, and here you will calculate the severity based on the opinion of the expert of the team. They said, for example, 10, from 1 to 10, and they said the severity is high. And what caused of the step or feature to go wrong? Cutting of sponge. Some surgeon, they will be cut some sponge, and this is maybe will be not in the counting when is starting the operations. The occurrence, because not in every operation, that means this is 5 out of 10 is 5. And what control existing? There is a policy on the sponge count, and because of the availability of the control, the detectability and detection was 3. When you are multiplying 10 by 5 by 3 will be 150. Here we will do our actions by doing staff orientation, and who's responsible will be OR head nurses. And what we did orientation and completed in 5/12, for example, 2021. When you are again looking for severity, will be stayed at 10 because retained to the retained sponge, and because of the occurrence will be reduced to 1 because now you do orientation to the staff not doing these things. About detectability will be stayed the same, but when you are multiplying 10 by 1 by 3 will be 30. That means we will reduce the RBN, risk priority number, by using only one action. When you are going to another process and you will do this failure mode and effective analysis form to help you how to predict any incident will be happen in the future, and how you are mitigated or how you reduce the severity of this risk. Okay, action hierarchy is when you are doing RCA or doing a failure mode and effective analysis, we are trying here to, there is some action will be taken during our action plan. We have strong action, intermediate action, and weak action. But looking here about what is easy for you, you are trying to looking for the strong action, like for example, in engineering control by using forcing function. This sure will be eliminated use of universal adapter to avoiding IV tubing misconnecting. This is one of good when you are doing replacement to the structure. Replacement to anything, not only, for example, when you are using also unlegible handwriting for a physician and you are using manual prescriptions, when you change it to electronic, that means this is one of the strong action. But when you are doing, for example, staffing workload, or you added some staff in pharmacy to be read back and read the prescription 2 times, this is also one of the intermediate action. Also the double check sometimes not so, but if you put it system to do double check, not depend on the individual, that means we'll go to the strong action. Double check is one of the weakest action because you are depend on the person, and sometimes we are saying training. This is also from the weakest action may be taken during your planning or corrective action plan. Okay, red rule. This is one of the important, also cannot be broken. If you number easy to be remembered, associating only with a process that can cause serious harm to employee, customer, or product line. Must be followed exactly as specified except a rare or urgent situation. Important here, every worker, regardless of their rank, experience, or company, to stop the work or production line, the red rules is violation. For example, in case some doctor coming to do some procedure and the doctor, he didn't has a privilege, the nursing, it has the right to say, stop. This is the red rule, not to be broken from anyone or violated from any staff working in the organization. Safety hazards, this is one of the important tools to be used for improving patient safety. A short stand-up meeting, 10 minutes or less, that typically used once at started each workday shift. And this is also hurdles. The daily hurdles will give team a way proactively managing quality and safety, that including review important standard compliance issues and output of previous quality improvement project. Staff recognition related to the patient safeties, like good catch, you can recognize the staff who's catching any incident before reaching to the patient, review performance, and look ahead for flag concerning proactively. Leadership safety walk around, one of the important patient safety essential tools. Senior leaders use weekly patient safety leaders walk around to demonstrate their organization commitment. This safety round will be conducted in the department in each unit, for example, emergency department or operation rooms or any pharmacy laboratory. The important here that the leaders will be meet the other staff, frontline staff, and they are able to talk about any safety issues directly with the leaders, and able to recognize them in case, or rewarding them when they are good in performance about patient safety. We have here the third poll questions. What are the most commonly used patient safety tools in your institution? You can select more than one. A, ask me. 3, B, speak up. C, 5 whys. D, cause and effect analysis. Failure mode and effective analysis. Action hierarchy. Red rule, safety hurdles, and safety walk around.
Please post your choices in the poll. You can select more than one.
Till what? You are not able to select, or what?
Okay.
Okay.
Let us just check answers or response.
I think they have problem with this. No answer here. I think they have problem.
Yes, I think there is a technical problem.
Because of time, we will do.
Type.
Section 4. I'm sorry, Dr. Tariq.
Yeah.
Patient safety governance, rule of governance, and rule of everyone. Rule and responsibilities. Everyone has a role in patient safety. Sure, we frontline staff, clinical or non-clinical, they have role in patient safety. Administration and management. Organization leaders and governance bodies, they have role also in patient safety. All of us who working in the organization, we have responsibility in patient safety. What can governance do? Could you participate in chat, please? Okay, commitment, you mentioned commitment to highest level shared value and belief, one of the important necessary resources, incentives, and rewarding to allow commitment to occur. Safety is valued as the primary priorities. Communication is candid and frequent between staff and administration. This is also the tools of walk around is will lead, and we will using also open door cultures. What can I do? What you will do if you are working in the organization? Participate, correct? Report, support, teamwork. Okay, we will work as a team. Obligation to listen when others have a concern, ability to speak up and raise concern, use a system analysis approach which look at the process and how it's lead to the error as opposite of focusing on individual blame. And last one, error reporting and disclosure of error to be considering as a two important concepts. As you know, we cannot avoiding mistake and we cannot eliminate totally, but with a good process and systems, we are able to let the mistake and we're trying to prevent it not reaching to our patient, and we will make our organization safeties. This is our references, and if any question, and I'm here. Thank you so much.
Thank you, Mr. Aid Rashidi, for this fruitful talk and a very interesting subject. We have here two questions sent it from our attendants. The first one, I think this is an interesting question because it's regarding the basic knowledge about patient safety. This question talk about what is the international patient safety goals. International patient safety goals. Okay.
International patient safety goal, as we know it, is by JCI, is covering 6 areas. Is one of the important. What is a hospital is accredited or non-accredited, he should look for these areas about 6 standards related to the 6 goals. Talking about how we are identifying our patient correctly. And I think in every organization should be provide a good policies or procedure to how do a unique procedure to identify your patient, at least 2 identifiers. Second thing is talking about effective communications. And this is effective communication not only because of when you make order, verbal or telephone order, we are also during the communication between when we are make endorsement between unit to unit or patient from staff to staff. Third one, talking about high-risk medications, and fourth, talking about the surgery, correct site of the surgery or correct surgery itself. And fourth one, talking about infection and associated infections. And the last one is talking about the risk of fall of patients. And this is one of the important things to be all of us working in these 6 areas, be covering by policies and procedure and trying to train the staff. And we keep some, we will be some KPIs to monitoring them very well.
Thank you, Mr. Aid. Our colleague or attendants also sharing their knowledge in the chat, which is an interesting act from them. The second question from one of our audience talk about debate is a debate between what is the patient safety concept. Is the patient safety concept independent from quality management concept?
As you know, the quality definitions is by HRQ. He said the quality is when we are doing the right things at the right time and for the right person, and you will reach the possible good outcomes. About patients, safety is also defined to prevent our patients to not reaching has injuries, as I said, because of our intervention or our systems. When you're looking for this two definition, you will find the patient safety is one of the important domain in equality, because when we are implementing patient safety, that means we're trying to implement system, we will trying to reduce the variation, we're trying to implement protocol or any policies helping us to let definition or concept of equality to be implemented when you correct procedure, correct time, correct person.
Very nice. We got a very nice comment from our colleagues. One said that safety is one of the dimension of quality dimension. Safety is one of the dimension of the quality. Also, another comment, brilliant comment, talk about no quality without safety. No quality without safety. Okay, I think there are 2 minutes remaining, and there is a debatable questions. This debatable question talk about is there is a difference between just culture and blame-free culture?
Okay, this is one interesting question. Maybe I didn't cover it during my presentation. Just framework of just culture is ensuring the balancing accountabilities for both individuals and also the organizational responsibilities. Everyone who doing any procedure, he has some responsibility regarding to any outcome will be from these procedures. And as you know, the just culture is not the same of no blame cultures, but it is a culture with individual accountable for willful misconducting from him. When we are saying just culture, that means he's okay, we're not blaming him, but he has some responsibility and accountability for his incidents happen. And we, based on our root cause analysis, we'll find, because sometimes incidents will be, it's happened because of some attitude or negligence. That means we were looking for just culture, not looking for any blame cultures. I think just culture, one of the important things to implement it in our organization, and every staff, they will be freely to do their work, but they should know they have some of responsibility and accountability about their work.
Okay, thank you, Mr. Raid Rashidi, for this short answers and direct answer. And I think we are on time. Thank you for all our colleagues sharing us. On behalf of Saudi Patient Safety Center, we would like to thank Dr. Raid Rashidi and the audience for their active participation as a part of the Saudi Patient Safety Center effort to provide you with a timely topic and interesting speakers. We had appreciated it if you would fill the evaluation survey provided at the end of this session. Thank you for joining us today, and we look forward to welcoming you back in the future webinars. Thank you.
Thank you, Dr. Tariq. Thank you to Saudi Patient Safety Center for giving me opportunity today. And I hope, inshallah, I meet your expectation and all attendance expectation. Thank you so much.